The following program is brought to you by the Center for Educational Outreach at Baylor College of Medicine.
My portion of the talk, in terms of focusing on new insights into autism, as a psychologist, I'm really going to focus on behavioral issues and assessment and some new ways that individuals are trying to approach the assessment, and a more fancy term for it would be phenotyping in individuals who are along the autism spectrum. So I thought I'd just start off with some facts about autism. I know this is a very well-cited statistic now that 1 in 150 children is diagnosed with autism. The male-female ratio in autism is 4 to 1, meaning that 4 males to every 1 female. So I thought this was an interesting statistic, that more children will be diagnosed with autism this year than with AIDS, diabetes, and cancer combined. And autism is the fastest growing serious developmental disability in the United States. So autism costs the nation over $90 billion a year, and this is a figure that's expected to double within the next decade. So in spite of those statistics, currently autism receives less than 5% of research funding of many of the aforementioned less prevalent childhood diseases. Although our hope, there was a new press release that just came out today about $60 million in NIH research being earmarked specifically for autism research. And that just came out today, so our hope is that that will change. So next, I thought I would start out just by talking about what autism is and what are autism spectrum disorders. So essentially, when we talk about what it means, we're talking about a triad of symptoms. So autism is defined by impairments in both verbal and nonverbal communication. And that's important because we're not just looking for children who are not talking or children who have a language delay. Many of the children that I see, for example, who have Asperger's syndrome didn't have language delays, but they still have impairments in how they use communication for social purposes. And by nonverbal communication, we really mean the use of gestures and sort of paying attention to more subtle cues related to communication. So the second piece of the triad is impairments in reciprocal social interaction. And some of the behaviors that we look at in that domain would include eye gaze, exhibiting a range of facial expressions, peer relationships and how children interact with their peers and play with them. So typically, a child will have impairments in those two domains, and those may or may not be accompanied by restricted and repetitive behaviors and interests. So the reason I say that a child may or may not have impairments in that third domain is because some kids meet full criteria for what we call autistic disorder, and those children usually have impairments in all aspects of the triad. Other children may have what we call PDD-NOS, or pervasive developmental disorder not otherwise specified, meaning that they may have a lower threshold of impairment in each of these 3 domains, or they may exhibit impairments in 2 of the 3 domains. And then we also have children who have Asperger's syndrome. There's a lot of discussion about how separate each of those quote-unquote labels may be. The key with all of them is that these impairments manifest before the age of 3, and really the way that Asperger's syndrome is defined, as opposed to autism, the differentiating features are language delays, an absence of language delays in Asperger's syndrome, and quote-unquote normal intelligence or cognitive abilities. What we're finding through recent studies is that the way that different clinicians classify Asperger's syndrome as opposed to PDD-NOS as opposed to autism varies very, very considerably. Okay, so how do we diagnose autism? Well, first and foremost, we typically examine a child's medical and developmental history. And the way that psychologists will typically take a developmental history, it'll be a very detailed interview. I know some of you in this room have done this interview with one of us. It's called the Autism Diagnostic Interview. We get very detailed behaviors about not only a child's current functioning, but what they've done in the past. So next, we would typically do a cognitive evaluation of a child, and we would select the instrument that we were going to do according to the child's developmental level. And that's actually very, very important, and I can speak from experience firsthand. I know when I first started seeing children with autism and I would give tests according to the child's chronological age, in some instances I would go, oh my God, I can't test this child, what am I going to do? So with experience, again, I learned that sometimes I needed to drop down and figure out where the child was functioning developmentally. And if I did, then we can often get a very nice picture of a range of their abilities: verbal, nonverbal, visual, spatial. So we would also be using a formal instrument to assess that triad of symptoms. Some examples of instruments that are commonly used would be the ADOS, or Autism Diagnostic Observation Schedule, the CARS, or Childhood Autism Rating Scale, or the GARS, the Gilliam Autism Rating Scale. So an important note about this, because I think in most of the research studies that we do, we would use the ADOS, the first instrument that's listed there, as well as the Autism Diagnostic Interview. There have been a lot of studies recently that have demonstrated that the instrument that's utilized to assess this triad of symptoms can really influence the diagnosis. So there's been a few recent studies that have shown, for example, that when you contrast the ADOS to the Gilliam Autism Rating Scale, the ADOS is more likely to pick up more children who are on the spectrum. And in one study in particular, they found that when the Gilliam Autism Rating Scale was used, it missed up to 50% of kids that were actually on the autism spectrum. So this is really significant if you have a child who maybe has some symptoms that are not quite as severe. We would also get an assessment of language, both receptive understanding of language as well as expressive language. Many of the children that we see have sensory issues, and so we would have a look at that, as well as fine motor skills. And then I've sort of put this generic label of medical issues, and I am going to get to that. The reason I've sort of kept it generic is because there's such a broad range of issues that many of the children that we see may exhibit. So some kids that we see have difficulties with sleep. Some kids may have seizures. Some kids may have GI issues. All of those things would be examined as part of a routine assessment. So what are some current questions in autism research? Well, I thought I would highlight this by talking about the Interagency Autism Coordinating Committee. And this is a group that's comprised of individuals from the National Institutes of Health, as well as individuals from the public. And they have just literally released their strategic plan from January of 2009. And these are all of the different areas that they saw as being very necessary to examine in terms of future research in autism. So the first sort of global theme that emerged was the issue of heterogeneity. What people are talking about now is that autism is not so much a unitary disorder with a unitary cause, but the spectrum is a broad range of disorders. And there are different causal factors and trajectories for different autism spectrum disorder subtypes. So just to give you some very practical examples, I see patients in the clinic who may be nonverbal and have some difficulties with aggression. They may have seizures. I see the completely other end of the spectrum of children who are in gifted and talented classes. And then there are all those kids in between. So what this committee is saying is that it's very naive to assume that all of the kids that fall within that broad spectrum would have the same cause for their symptoms. So a second sort of global theme is the issue of prevention. So the committee really wants to examine risk factors and potential environmental triggers. And there are examples that are being cited, for example, in heart disease or in diabetes. We know a lot about how to prevent those medical problems. We don't know a lot about how to prevent autism. So the committee is really calling for more research related to biomarkers, for example, and potential environmental triggers. The committee also wants to advocate for research studies that are focusing on earlier detection, because as we know, when you start intervening early, it really can make a difference in a child's trajectory. And that takes me to the next point in terms of assuming a lifespan perspective. So what's the natural history of autism? I have a patient that we saw just a couple of weeks ago who I first diagnosed when he was 2 years old. I would never have predicted that he would be doing as well as he's doing today. He has average intelligence, he's very verbal, and he's just doing fantastic. So part of the issue of this is figuring out how do we know who will improve and why will they improve and what treatments will help them improve. The other sort of broader theme areas that are listed from the committee include data sharing, which I think Dr. Bodette will talk about more from the perspective of genetic studies, utilizing resources, public-private partnerships, and more community engagement in autism spectrum disorder research. So for the rest of the talk, I'm really going to focus on the first point related to heterogeneity. So as I mentioned, the autism spectrum is so broad. I see kids who have mental retardation. I see kids who have some dysmorphic features, some who have language delays and some who don't, some who have macrocephaly, some who have regression, GI issues, aggression, genetic disorders that are well defined, such as Fragile X syndrome. We see some kids who have seizures. I see other kids who have, for example, a lot of compulsions and rituals. Some kids that I see have comorbid ADHD. Others have a very significant amount of anxiety. And I see the occasional patient who also has savant skills. So just to illustrate the heterogeneity, what I'm going to do is show you a video clip. So this first clip is of Tyler, and he's 8 years old. When we did his formal evaluation, we found that he had mild to moderate mental retardation. And in this clip, you are going to see our school psychologist and research assistant, Carrie Noel, who's in the back of the room there, doing part of the autism diagnostic observation schedule with Tyler. So that's Tyler, and just wanted to give you a snapshot of him. And after I show you this second clip, we'll talk about salient issues from both. So this second clip is of Alex, and Alex is 5 years old. He scored within the mild range of mental retardation on cognitive testing, and in this clip you will see Dr. Robin Kochel doing the same portion of the ADOS, just for contrast, and Robin is also in the back of the room. So a few salient issues before I kind of ask your impressions of what's going on. So what Alex was saying in that video, he was a little guy who had a lot, and I do mean a lot, of interest in certain kinds of vehicles. So when he first saw the blocks, what he was saying was GMC, GMC, meaning the car brand. And he was starting to get upset because he wanted those blocks to be Barney blocks, like what he played with at home. So that was partly what stood out about Alex. For Tyler, I'm sure you all noticed some of his repetitive behaviors with throwing the blocks up into the air and banging the blocks. And something that was just a little more subtle about Tyler was, one, Carrie had to prompt him to make verbal requests for more blocks. And then his eye gaze was not always coordinated with his vocalizations. And when he spoke, he would sort of tilt his head back like this. So one of these kids has an underlying genetic condition. So if you all would indulge me in a game, and let's figure out who it is. Okay, so how many people, just a show of hands, think that Tyler is the individual with the underlying genetic condition? Okay, and how many people think that it would be Alex? Okay, well, it's actually Tyler. Tyler has a mutation in the MECP2 gene, which is responsible for Rett syndrome. So, and Tyler's brother is also affected with this same mutation, and both his mother and grandmothers were carriers of this mutation. So I think it's to illustrate that you have two kids who both have autism and who both are exhibiting some similar behaviors, but each has a different underlying etiology. And for Alex, we don't know what the etiology is. So the broader assessment for each child was very different. For Tyler, he had a lot of tremors, and that was something that was he had more neurological issues going on. And so that obviously dictated a different route of interventions with him than for Alex. And then each child also has very different underlying needs, and their histories are different. So the resources in Tyler's family were very different than the resources in Alex's family. So that leads me to the next slide about whether or not these are pieces of this same puzzle. So unlike diseases such as Parkinson's syndrome or Alzheimer's disease, in autism there's no clear unifying pathology at the molecular, cellular, or systems level. More recently, Francesca Happy in her group from the UK have found that there's some evidence that the triad of symptoms may not exactly hang together, and they've done very, very large-scale twin studies and have found that there are really only modest correlations between those three areas that are involved in the autistic triad. They also examined those same three areas within the general population and continued to find only modest correlations within the general population. As more people have done research on the triad of symptoms, what they're starting to find is that the autism spectrum disorder phenotype is really composed of three factors. So there's a factor that's related to social communication, there's a second factor that's really related to inflexible language and behavior, and then a third factor that's related to repetitive sensory and motor behaviors. So people are now starting to advocate talking about the autisms, so studying disorders with related features, and that this may offer more insights into treatments or causes. And we're also advocating better defining subgroups of children with shared features. So I know I'm about to talk about the Simon Simplex collection. Just came up on a call the other day that one of the things that we really need to start doing is identifying subgroups of kids that have a higher level of symptomatology, maybe within just one domain of that triad, and then look for shared features amongst those kids. And that may offer more insight into underlying causes and then potentially underlying treatments. So this is sort of my new model of how to approach behavioral research in autism. So what our goal really is that by doing more detailed assessments in phenotyping, we will better identify subtypes or subgroups of children within the autism spectrum that will allow us to make more tailored recommendations for treatments, more insights into potential causes. The goal would be better prediction, again, of who's going to do better with what sorts of treatments, and then that'll promote investigations into new treatments. So just some recent examples of people using this particular model of research. This was a study that just came out from a group at Vanderbilt, and they found, for example, that a single nucleotide change in the MET gene is more frequent in families with a history of autism and gastrointestinal symptoms. And this variant shows no association with autism in families affected by autism without accompanying gastrointestinal symptoms. So I know that's sort of a mouthful, but basically they are finding that this variant is attributable to kids who have autism with significant GI symptoms, and they don't see the same variant in kids who don't have those symptoms. So there are countless examples of studies of very well-defined genetic conditions that are associated with autism. And the goals of many of these studies, for example, in Fragile X syndrome, is really identifying what we would call biomarkers or endophenotypes. So endophenotypes can consist of neuroimaging parameters, they can consist of cognitive parameters, a whole array of things. And so the idea is that maybe from the study of these very well-defined conditions, we can apply that to the broader spectrum of autism, and again, with the goal of offering more tailored and targeted treatments. There are also very recent studies examining differences between OCD, autism, and social anxiety, for example, in both children and adults. So there's a whole movement within the field about maybe there are sub-threshold traits that are within the broader population, and maybe we can learn more by studying some of these associated disorders, such as obsessive-compulsive disorder, social anxiety. There are even studies talking about the overlap between schizophrenia and autism, genetic overlap, that is. So now I want to switch a little bit to focusing on the Simon Simplex collection, and we would like to think of the Simon Simplex collection as an example of just the sort of research that I've been talking about. So the Simon Simplex collection is an investigation into autism. There are 13 sites around the country, and the goal is to create a large-scale collection of 2,000 families and create a repository not only of genetic information, but very, very detailed assessment and phenotypic information that can be used by researchers around the world. And Baylor College of Medicine, as you'll see on the map, is one of the sites. So the leaders within the Simon Simplex collection, Jerry Fischbach is the scientific director, and Catherine Lord, who created the ADOS and the ADI, is really the lead investigator for the Simon's collection. And I have to tell you, I've never been part of a research study that has had so much oversight. So Kathy Lord is very, very rigorous in her standards of assessment and phenotyping, and we're constantly having to submit videotapes to demonstrate that we are all doing these assessments the same way. So to be eligible to participate in the Simon Simplex collection, you have to have one child with an autism spectrum disorder who's at least 4 or older. They also have to have one or more siblings without an autism spectrum disorder who's 4 or older, and then unaffected biological parents who are both willing and able to participate. So the benefits of participating in the Simon's collection, you would get a free assessment, and we have links to a website up here that's a way to stay informed about study-related scientific findings. And that's SAFARI stands for the Simons Foundation Autism Research Initiative. And our hope is that by participating in research, families will feel as though they're contributing toward our understanding of new treatments. So if you want to learn more about the Simon Simplex collection and what Baylor is trying to do in terms of our participation, you can contact any member of our Simon's research team, and they're all at the back of the room. They have brochures outside, and we've listed the phone number for one of our coordinators here. So just to close, and then let Mrs. Cooper come up and participate, I have a lot of acknowledgements up here. Robin Kochel, you saw her doing one of the assessments. She's the project coordinator for the Simons collection at our local site. You also saw Carrie Noel. Christy Bruton and Morgan LaSala are also at the back of the room. Sherry Sellers-Vinson is right up here, and she's also one of the investigators in the Simon Simplex collection. Dr. Bodette and Dr. Treadwell-Deering are the principal investigators. And last but not least, I have learned so much from families and children through the years that I've been doing this. And so your participation in research is just invaluable, and you continue to educate us and advance our knowledge of the field. Thank you.